without any further ado, I'd like you to welcome Professor Tracy Levett-Jones.
Thanks, Jo. Okay, so for those of you that have been practicing a while, it's easy to look at this model of clinical reasoning that you're probably familiar with and I'm going to talk about again and say, look, really, it's one of those, academic models. Academics always come up with some sort of model to, sound clever. I think clinical reasoning is what good nurses do and have done for centuries. They may not have had the title clinical reasoning. They may have not given it a title at all. It may have been clinical judgment, clinical decision making, critical thinking, but good nurses do this. It's part of their everyday way of being in the world, but they probably don't think about it. Now, the research shows that in intensive care, registered nurses engage in clinical reasoning every 30 seconds. There's been research on medical surgical wards to show that nurses engage in clinical reasoning 50 times every shift. And that's observational research, watching RNs and getting them to think aloud. So we know it happens. I think one of the things, yesterday when we did the same similar workshop at Launceston, people were saying, I don't really know how I do it, how I teach it, how I communicate it. And I think that's because it's so deeply entrenched in our long-term memory, we're not even aware often that we're doing it. So if I asked you to put your hand up and say whether you think you're pretty good at clinical reasoning, put your hand up. Come on. I am not one person, two, three. This table's pretty good. So if I come to hospital, I want these people to look after me. There has been some work done, and it hasn't been done in Australia, it's been done overseas, to show that registered nurses with 10 years or more experience, 75% of them will have a safe level of clinical reasoning skills. 25% of them won't and will probably never get to a level that's safe. And I'm going to tell you about that study a bit later. But those 25% are probably what Benner calls the experienced non-expert. So they've been doing the same thing the same way for 10, 20, 30 years. And I suspect you all know those sort of people. And they tend to sometimes rise through the ranks, but they never really develop expertise. And sometimes I think they are the least safe because they have a reputation because of their years of experience, but they're never the sort of person that is profoundly good at their job. But the other 75% are pretty good, generally. So the dilemma is, do we say, look, hopefully most students, most graduates will develop clinical reasoning skills, just expose them to clinical practice. Eventually it's bound to happen. Or do we say, yep, we could teach it at university, reinforce it on clinical practice? Or do we say, let's just leave it and wait and see? 75% will probably get there by the time they're 10 years. Have 10 years experience. And that's some of the things that we're going to be talking about today. Could we teach clinical reasoning, or is it such a nebulous thing that we can never really teach it? Okay, so some of the things you're going to be thinking about. And one of the things I want you to be thinking about through the whole day is, do you teach clinical reasoning? And if you do, how do you do it? And if you do, how do you know it's actually working? And clinical reasoning to me is one of those things much like driving a car. We drive a car, we often go on automatic pilot, particularly if it's a really familiar route. We just know we do it and we're pretty safe. We don't realise that we're doing the steps we're taking until we have to stop and teach someone else. And then we realise that there's multiple steps, multiple hidden tricks. So, if any of you have taught kids to drive, you know that they focus, I can drive the car, I can change gears, I can do all that stuff, but they forget all the peripheral stuff. They forget the mirror, they forget to check the lanes, all that stuff that is so unsafe. That's a bit like clinical reasoning. We can teach the basic steps, but it's what's happening around, the contextual things that can trip us up and can trip them up. So we're going to talk about that today. We're going to talk about why clinical reasoning matters, because it really does. I'm going to tell you a little bit about our story at Newcastle. We're going to share with you how we came to a definition of clinical reasoning that we use, how we developed the model, why we developed the model, and then talk about some of the errors and how we develop clinical reasoning skills. And I'm going to show you a couple of videos to show what goes wrong when we don't engage in clinical reasoning, or when our clinical reasoning is influenced by a whole lot of biases, prejudices, and assumptions. Okay, why it matters? We know that nurses with effective clinical reasoning skills have a positive impact on patient care and patient safety. Those without good clinical reasoning skills have an adverse effect on clinical safety. And that often results in a failure to rescue. And the irony of that is that patients come to hospital or they engage with health professionals in all sorts of contexts in the community and in aged care, thinking that their engagement with a health professional will be a safe encounter. And often it is the least safe encounter they can ever engage in. There is really good research to show that it is safer to work in a nuclear weapons plant, safer to go hang gliding, safer to climb Mount Everest than it is to be a patient in an Australian healthcare institution. So healthcare is dangerous, and there's not just because of the people, because of all the interactions, the complexity, the human errors that occur, but also the system errors that occur. But most of those errors are not related to a lack of procedural skills and not related to a lack of knowledge. And that's what we tend to focus on. Certainly in undergraduate programs, we make sure they've got knowledge. We examine their knowledge, and we focus on their skills. We assess their skills, we teach the skills. They go into a clinical context, they're assessed again on their skills. For decades, those two things are what we're focused on. And a bit of communication, because we want them to be nice to patients. Haven't really taught communication too well and haven't assessed communication too well. And the irony of that is that 70% of the errors in healthcare are related to communication. And I'm going to be talking a little bit about that later today. So we're not doing that too well. But 57% of adverse clinical events are related to clinical reasoning errors or cognitive errors, not just in nursing, but in healthcare. So we've got all these errors happening. We know more about thinking than it is about skill, and yet we haven't really focused on that. And we haven't really, for a long time, didn't actually define what we meant, didn't know how to teach it, and certainly didn't assess it. So adverse patient outcomes are incredibly common. Nearly 17% of hospital admissions result in an adverse event. Now keep in mind, they're the ones we know about, and it's a little bit like medication errors, and we see the tip of the iceberg. These adverse events, we're only seeing the tip of the iceberg because often adverse events happen and they're not reported as an adverse event. They're reported as a complication of surgery, or this patient was palliative, so they were dying anyway. The fact that they died 6 months earlier because of an adverse event isn't often factored in. So this is the tip of the iceberg. So how many patients are in Royal Hobart Hospital?
About
200. So do the maths. What's 16.6 of 200? 33.2 patients. So this week, 33.2 patients from Royal Hobart will experience an adverse event, and 16 of them will be preventable. And an adverse event is serious. Okay, that's not just a minor thing, not a minor medication error that didn't cause any harm. These are serious adverse events. And of those, 13.7 will result in permanent disability. So, acute kidney injury or something incredibly serious, and nearly 5% will result in death. So these are big figures. And when I started looking at this, and I've got a real vested interest in patient safety, and if I get a chance later, I'll tell you about my really dear friends whose 16-year-old daughter died 6 years ago from a preventable adverse event. I'm really vested in this. But part of me, when I was talking to students, now I can talk to you more confidently because you know healthcare and you know the good, the bad and the ugly, but you also know it matters. Imagine talking to students about this, and we start talking to students about this in first semester, first year. I wanted to do it in a way that didn't say, oh my God, I'm going to kill people. It's so dangerous. I wanted to do it in a way that says, you can make a difference. This isn't inevitable. We can change these figures. If we learn the skills, you do need knowledge. You do need clinical skills. You do need clinical reasoning skills. You do have to communicate with patients and with each other and with other health professionals. And that's why you're enrolled in an undergraduate program, because we want to move you through those processes. So I didn't want to say this is terrible, because I think healthcare is amazing and I think nursing is absolutely amazing. So what does it equate to in Australia? 13 jumbo jets crashing and killing all 350 passengers every single year. In America, that's every single month. So if we knew that, would we be getting on planes, readily? And yet we have no choice about going to hospital. We have no choice about engaging with health professionals in the community, in mental health or in aged care. And all of those areas, errors happen in all of those areas. It's not reserved just to acute care. So, to education. Why does it matter in education? There has been some really good reports done in New South Wales, and this is a New South Wales statistic, that showed the incidence of errors attributed to clinical reasoning escalated as new graduates entered the workforce. So the beginning of each year, and then little escalations throughout the year when the new set of graduates came in. Not just nursing graduates, also medical graduates. So we knew there was a problem. Now in the United States, is anyone here from America? No? In the United States, they have what I think is a really interesting approach. Students graduate from either a 2 or 3 or a 4-year program. They graduate and they go and start working as a registered nurse. Within 6 months, they have to do an exam called an NCLEX exam. And they have to pass that exam in order to continue practicing. And they have a couple of attempts, but not unlimited attempts. Universities who have a cohort of students, if 75% of those students don't pass the NCLEX, then the university they came from lose their accreditation. So they've got a real vested interest in getting students to pass the NCLEX. And they say it's an exam that focuses on clinical competence and critical thinking. And I have seen the exam and I think it's pure knowledge recall. It's very hard to test clinical reasoning and competence using a multiple choice exam. But irrespective, they pass and generally they get through, and generally more than 75% pass. So Dorothy DeBuno did a study of students that had graduated and passed that NCLEX, and it was before they had been practicing for 12 months. And what she did was show these really good videos, clinical videos, that prompted the participants to make a clinical decision, and there was a clock. So they had limited time to make the most appropriate decision. And she found that 70% of them scored at what she rated to be an unsafe level. So they had passed, they had graduated, passed the NCLEX, were working as registered nurses. 70% of them were unsafe when it came to clinical reasoning. She gave the same study to registered nurses and with more than 10 years experience, and 25% of them scored at an unsafe level. So we've got a bit of a problem. So we know probably most people will get there by the time they've got 10 years experience, but about a quarter won't. So this is a problem because this relates to patient safety. But just like we've found, those registered nurses, those nurses had good knowledge and good procedural skills, but they just couldn't respond appropriately to rapidly changing clinical situations. So a little bit about our story. And this is, true confessions. So when I started at the university, I was a bit of a, what's a nice way to say troublemaker? I was, I gave critical commentary sometimes because I've only been there. I still consider myself more of a nurse educator than an academic, but I know I can't get away with that for too long. But because I could say quite openly, I can't believe some of the things you're doing at this university. Newcastle is a great university, but some of the things they were doing I didn't think were clinically, just weren't right. Things like assessing students in their final semester with essays. I thought, by that stage, if they can write essays, that's good, but I don't really care. I want to know they're ready to work as a beginning registered nurse. So I started to think about ways we could change it. So one of the ways we changed it is that now students they are assessed in practice by a university-trained assessor, and the assessor just is basically a fly on the wall, just observes their practice, documents everything they do, then does an oral exam with them and then rates them against the Nursing and Midwifery Board of Australia Competency Standards. I have to keep saying that because it's not ANMC anymore. Rates them. And they'll get one of three results. Competent on this occasion, not competent on this occasion, competent pending specified remediation. They have to have a competent rating. They have 2 chances in order to pass that course and graduate. So we brought that in 2005. And that gave us the most amazing data. It allowed us to see the things that we were teaching really well and the things we thought we were teaching that we weren't. So we worked out pretty easily that 50% of our students didn't wash their hands properly. So we could deal with that. So now that's taught and assessed. About 50% weren't giving medication safely, so we could deal with that issue. But what the assessors started to say to me is, they're not bad, but you know what they lack? They lack insight. They lack critical thinking. And when they say they, it's, how we are very typical, those students, we put them all in one category, lack insight, lack critical thinking skills, lack not great at problem solving, and they use different terms. Their clinical judgment's really poor sometimes. All those things, and I was thinking, define that for me. Tell me what that looks like. So they were able to give me little examples, and I was thinking, so is that insight? Is that common sense? Is it critical thinking? And I started to realise we've got a bit of a problem. And they were documenting on the section of the appraisal form called critical appraisal, one of the domains. What is it? Critical
thinking analysis.
Thank you. See? Good student. Critical thinking analysis. But that's really more about how you analyse the literature, and it's more about research. It's not about so much critical thinking in practice. So they were documenting it there because they had nowhere else to document. On the whole appraisal form, it didn't say, has this student got good clinical reasoning skills or critical thinking skills? So they were putting it there, but we knew we had a problem. But when I started to go through the actual documentation, and they were huge, imagine if you're assessing someone, write down every behaviour and every action, everything they say, it's all documented. I started to do an analysis, and after 2 years, I had 1,031 of these documents to go through. And what I realised was it wasn't so much insight or problem solving, it was something nebulous that I thought, it looks like clinical reasoning. So I got the team together, a great team at Newcastle, and I said, I think it's clinical reasoning. You've got to solve the problem. I'm very outcomes focused. Got a problem, let's fix it. I think it's clinical reasoning. And they said, hang on a minute. Why are you calling it clinical reasoning? How do you know it's that and not judgment, not decision making, not critical thinking? Let's just call it something. And they said, no, got the team together and we did some research, and we found there's so many different and interchangeable terms. They agreed after a while that clinical reasoning is probably the most appropriate because under that umbrella comes critical thinking and comes judgment and decision making, because you need the judgment before you can make a judgment. So it sort of all fits up there. But what we realised is we didn't have a great definition, and if you can't define something, you can't teach it. If you can't teach it, you can't assess it. I think it would be, a quick workshop, let's solve the problem, turned out to be 8 months before we could actually come together and really say, this is what we're going to do. I was very fortunate because I worked with someone, Mary Hoffman, and her PhD, she had sat in intensive care, and she had given registered nurses microphones and taught them to think aloud. And so after researching a number of them, she worked out that there was a difference between really good, confident, kind of expert nurses, although some of the experts weren't very experienced, and those that were really quite muddled in their thought processes. But consistently, the outcomes with the group that had good, logical, consistent thought processes, the patient outcomes were always better. So we used a lot of Kerry's work. We used Christine Tanner's work. We used what I think is Australia's probably first and best nursing researcher, Betty Anderson. So we brought in a whole lot of work, and we looked at what was the consistency, what were they saying. And then we said, we need a model. We need a model that engages students, that they get, that we can use it to teach, and it is accessible, both on campus and in practice. So as I said, we had to come up with what it is. Now, do you think nurses' clinical reasoning is different to other health professionals' clinical reasoning? Because this is one of the questions we battled with. Come on, be brave, tell me. No? Why would you say that?
Because the processes are still the same. What you're actually probably investigating and assessing is probably a little different, but I
Yep.
think the process is still the same.
Okay. Would anyone else agree or disagree? Or we were talking.
A bit more holistic, so we'll be taking into social factors and, the broader bits of their life into it, as opposed to fast we've got the,
I think that is probably one of the key differences. My daughter's studying physio, and she said, they do clinical reasoning in a fashion, but it's very much identifying red flags, yellow flags. Yellow flags are something they can address then and there. Red flags are ones that are bigger, socioeconomic, psychosocial issues. They move them on. Yeah, that's not our problem. We focus on this. Those areas are important, but they're not our problem. But I think nurses can't do that. Although we make appropriate referrals, we also look at the whole person. Nurses can't avoid doing that. That is part of what makes us different. And I think the other thing that makes us different is that we don't treat and retreat. So we can't go in, done clinical reasoning out, because doctors can come in and they assess well and they make clinical diagnosis, they prescribe orders, then they go. Nurses, clinical reasoning is cyclical. So we will identify a problem, we'll deal with the problem, we'll come back and say, did it make a difference? Didn't work? Start again. Or come back and go, I've got a new issue we need to resolve. May have been physical, might have been pain, now it's psychosocial, now it's emotional. So it's a continual iterative process. And I think that makes us different in some ways. I was telling Angie over breakfast that we have these clinical reasoning posters on the wall of our tutorial rooms, and other students, medical students, pharmacy, occupational therapy, all use the same rooms. And the OTs and the physios said, that model is great, can we use that? So they've now started to use that model. And I presented at a conference in, Tuscany a few months ago. And I do some work at Keele University in the UK, but some of our medical colleagues from Keele were there, and I'm going back next month because they want to learn how to use clinical reasoning, which I thought was amazing because I thought they should be teaching us. I actually think medical students, well certainly at Newcastle, they use a hypothetico-deductive model quite well, but what they do is, and I'm going to talk about some of the errors later, is that if that model works, it's good, but often there's so many things that interfere with the deductive process that errors happen, and I'm going to talk about some of them later. Now, there were some people in my school, and certainly some of the clinicians, because we had a whole lot of clinicians involved, that said, you're trying to teach something that's too nebulous, that can only come through experience. It's not something you can teach. It's something that's either intuitive. You are either a gifted nurse with these skills, clinical reasoning, critical thinking, whatever you call them skills, or they're not. And they'll get weeded out one way or another. And I said, well, I don't think that's fair, and I think you've got to teach it if you're going to assess it. And we had planned to assess it. We thought it was so important. I have to say they've come around now, and they're really good. But then we had to say, so what is the best way to teach it? Where do we teach it? I don't think you can stand up the front like I am and give a lecture on clinical reasoning and say, great, you've got it, now you'll be examined on it at the end of the semester. It's so much deeper than that. So we had to battle with a whole lot of ways of teaching it, and we do it in multiple ways. We do introduce it to first year students in a lecture, but only to say this matters and this is why. But then from then on, they're fully immersed in it. Tutorials, through online processes, in simulations, and in practice. Although we're not as good, we haven't got this body like you guys at Newcastle yet, and that's why I'm really in awe of what you're doing here, of clinicians, facilitators, preceptors that understand the concept and why it matters as much. I think we're making progress, but they're certainly not as committed as you are here. So this is the definition that we've come up with. Clinical reasoning is a logical process by which nurses and other clinicians collect cues, process the information, come to an understanding of a patient problem or situation, plan and implement interventions, evaluate outcomes and reflect on and learn from the process. So I love colour, so we chose a really colourful model. It looks perfect, it's perfectly symmetrical. It looks like it's all got the arrows pointing all in one direction. Now, wouldn't that be nice if it always worked like that? It doesn't. Sometimes those stages merge, sometimes they blend, sometimes they overlap. There's a lot of going backwards and forwards. The problem happens when we go from the red one, which is just consider the patient. I've walked in, I've seen the patient, oh, I know what's wrong, and it's straight to action. That's when the problem is happening, because there's no thought process that's underpinning it. It's just a reactive decision. I've seen that, I'm going to do that. Now, I will qualify that statement because it's a little bit about sometimes good clinicians seem to do that, and students see them do that, go in and they go, right, I'm going from there to there, I'm doing this. Really what's happening is there's a whole lot of thought happening that's almost, it's long-term memory, short-term memory, but it's so deep that even the clinician themselves isn't aware of the thought process that are going on. They have just seen this before. They're reacting because they know. They can predict, they can match patterns to what they've seen before, and they know the right action to take. And it's not just reactive. It is such a deeply ingrained, thoughtful process that it is logical and it is systematic, but it's just not on the forefront of their minds. Now, the big challenge for that is that students don't see that. What they often see is registered nurses walking in and doing something with it, and they think, well, there was no thinking there, that was just action. Or sometimes the RN will say, oh, well, I'm doing that and I did it for this reason. So they've got a rationale, they've seen what the RN did and they've got a rationale, but they haven't seen a thought process. So how can they learn it if they don't see it? They see what you do, they hear what you say, but they can't tell what you're thinking unless you are one of those rare individuals that are really good at thinking aloud. And that's hard to do, very hard to do. Okay. And as I said before, clinical reasoning is not go in, do your obs, get your patient showered, done the clinical reasoning for today. And if you're really good, I'll do a bit of person-centred care as well, and then I'm out. It is a cyclical process. I'll mention person-centred care because this challenges me all the time. Sometimes clinicians say, Tracy, person-centred care is good idea, but we are way too busy. The same as clinical reasoning. It's good, but we are way too busy. And I think, but it doesn't actually take any more time to communicate in a way that's person-centred. It doesn't take any more time to engage in clinical reasoning properly. And for the good nurses, it's just the way they operate. It's not another job to do. But when 70% of the errors in healthcare-related communication, I think we need to focus more on person-centred care. But I will say, and I said it yesterday, one of the most person-centred people I've ever worked with, and I'm so fortunate now she works with me at the university, but she was the person when I walked on the ward as a scared, probably a bit ambivalent, student nurse, walked on and thought, what am I doing? She was the very first person that met me there, and I watched person-centred care. Before we had a term, I watched clinical reasoning before we had a term, but I just thought that is the sort of nurse I want to be. So I think we've invented terms, like term person-centred care. We've come up with clinical reasoning, but good nurses just do it. It's just part of them. Okay. What is this? You're all good clinicians. You should be able to see what this is straight away. And you're not, if you've seen it before, you're not allowed to say it. Someone brave, put their hand up.
Map of New York.
Map of New York? Someone said it was a map yesterday. You're completely wrong.
I knew that.
Okay. Come on, someone else take a guess. What did you think?
Small part of a cow's face.
Small part of a cow's face?
Blown up.
Well, do you know psychologists will say in any given group that 25% of people will see the image within 15 seconds. You are right. They're much cleverer in Hobart than they are in Launceston. Nobody got it in Launceston. Oh, do they? Can you all see the cow? Now can you see the cow?
We rang him up this morning.
I did not. Now, the reason I showed you that image is, if we go back to that, you can still see the cow? Yeah. Who said no? Oh, look. Am I right? Here's the nose. There's the eye, the ears. Oh, they're not so bright after all. Okay. He probably comes from Launceston. Okay. So the reason I'm showing you this is when students go into clinical practice, that when they see patient scenarios, they'll do one of two things. They'll see a list of jobs that have to be done, because that's their safety net. I can do the obs, I can do the showers, I can do this. They'll focus on that. But if you try to get them focused on the big picture, what's actually happening in this situation, it's as clear as mud. It looks like that to them. What it needs is for you to point out the subtle nuances, to point out the details, to help them recognise the consistent pattern within the complexity. Now, we also do this on campus. We teach this on campus, this, and we have real scenarios like, and I'm sure you do at UTAS, but at Newcastle, we use real scenarios based on real patient situations, and we point out the nuances in the hope that when they go into clinical practice, they'll be able to say, hypotension, weakened thready pulse, poor urine output, dry mucous membranes. Put all that together. That could be hypovolemia or dehydration, because we want them to be able to see some of the things. It's really important that we do that. But it's even more important that good clinicians, preceptors, facilitators, they point these patterns out in clinical practice. Now, after a while, these patterns become so firmly ingrained in you that you see the patterns without even stopping to consciously think about them. But students don't. It's all blurry to students. And it's like them, one student said to me, I feel when I'm in a clinical situation where there's a degree of complexity, and remember, they considered complexity not to be someone in septic shock, but someone who's a bit dehydrated post-op, someone who's got some pain. They see that, for them, that's a complex situation because they think, what am I going to do? They said it feels like wading through toffee, sticky toffee, because they just can't make sense of it. They need you to point it out. Okay, I'm going to go through this quickly because I think, are most of you familiar with this? Yep, okay, so we can do it really quickly. This is what the research says that effective nurses do. They don't do it perfectly, obviously, but they do it in a consistent way. Effective nurses, okay. So they start with, they see the patient, they understand the context, they see what's going on around the patient. And then they start to collect cues. They look at the patient, they work out what assessments are needed for this patient at this time in this place. So while routine vital signs might be done on every patient, the really good nurses will say, yep, I need the vital signs, but what else do I need? I need to look at this chart, I need to review what information I've got, I need to reflect on what I heard at handover, I need to look at the pathology results. They work out what cues are essential for that situation, that patient at that time, and they're able to recall the relevant knowledge. And it may be about the pharmacology, pathophysiology, it may be legal law knowledge, ethics knowledge. They're able to just pull it because they have it. And I tell this to students, they actually say, I nag them about the recalling knowledge, because they're actually pretty good at Newcastle, but if they ever think about not attending tutorials or lectures, I say, well, that's great, because you may be able to do the skills, but if you haven't got the knowledge to recall, you can't run out and look up your textbook when there's something going on. You've got to have the knowledge, you've got to be able to draw on it just the way good clinicians do. Now, you may look at this cycle and say, well, really it's not that dissimilar to the nursing process, which I'm sure many of you learnt, and then probably, if you're like me, forgot. The difference between this is that it provides a level of detail. So it says to students, the type of cues you collect are these. They're the assessment ones. They are the information you currently have, and it's recalling knowledge. So it gives them explicit detail. And then it gives them detail about how to process it, the steps that are needed. So it's about interpreting. Is it normal for this person at this time in this place? If it's abnormal, hold on to it. That could be really relevant. Discriminate and say, yep, I don't need that at the moment. I need more information. I've got to go back and check their urine output. I've got to check their cumulative fluid balance. I didn't get everything I needed. It's about, and I think the relate one for me is the one I love, because I think this is what makes nursing an art and a science. It's about what is the story with this patient at this time. I've got all these bits of cues. I know what's abnormal, but what's the story here? It's about bringing those clusters of cues together and say, whoa, that equals that, I think, or it could be that. I'm preferring this, but it could be that. It's about creating the story, and that way it's not a whole lot of facts. And I say to nurses that are students that are getting a bit lost, and they're losing their way in nursing, I say, pretend you're an investigator. Every single patient will have a story. You've got to go down. It's not on the surface. You've got to drill down and find the story. And when you've clustered the cues together, you make an inference. I think it's this. Now the last two, the match and predict. Match and predict are very much, I think, expert thought processes. Because expert clinicians, and when I say expert, I think you can be an expert after a few months sometimes, because it depends on who you are and your way of learning and how good you are at learning. But expert clinicians can say, I've seen this before. I know that it's not unusual for a day one post-operative patient following a bowel resection to be hypovolemic. I've seen it before. So I can match that. It looks just like that. Signs and symptoms are exactly the same. Yep, I think it's probably that. And because there's a whole repertoire of previous experiences and stories, they can recall those experiences. Students don't have that, so they need you to say, I can tell you it's probably this because I've seen it and it looks like this. And predict. Now, the predict one is what catches nurses sometimes, because we fail to predict. If I do nothing now, what might happen? We were talking yesterday about behavioural psychology, which says that human beings are destined to be optimistic. And I think nurses are very optimistic people. So they will say, it could be this, I'm just going to watch and wait because I think, this person's young. I think they're probably going to be okay. Or if I ring that doctor and it's nothing, he'll think I'm overreacting. So I think they'll probably be okay, so I'll watch and wait. But the predict says, if I do nothing and it is something serious, what might happen? And it's the predict that often causes people to take action, even when they don't really want to take action, and even if they're not really sure they should take action. Now, the next one is about identifying the problem and coming to a definitive diagnosis. Now, a lot of nurses don't like the term diagnosis. They think doctors do the diagnosis. That's not our job. I think we have educated nurses that are quite capable of making nursing diagnosis, not medical diagnosis. You are all quite capable of saying, this patient's dehydrated, this patient's hypoglycemic, this patient has acute unremitting post-operative pain. We can make nursing diagnosis and we're good at it. And if we don't have a diagnosis, then we don't actually know what to do next. And that's important because we've got to establish goals, and the goal should be timely. So if you've got a dehydrated patient when they've had a urine output of 30 mils over the last 4 hours, you know that this is a serious situation. If you do nothing, they could end up with acute kidney injury. So you say, I've got to get their urine output. That's my goal, and I want it to happen within at least an hour. So you've got something to hold on to because you need that in order to evaluate whether it's been effective or not. Whoops, take action, said that one. We've got to evaluate the effectiveness of that action. So if the urine output is still low 2 hours later, you know that you've got to start again because it hasn't solved the problem. And reflect or contemplate what you've learned and what you could have done differently. And you've all learned about the importance of reflection. Students learn about the importance of reflection and it becomes like, oh God, not more reflection. But we all do this. We do this on the way home in the car. We do it all the time and think, oh, I really should have phoned the doctor then, or I really wish I'd done that differently, or I really wish I hadn't said that. We do it. We just need to be more explicit about it. Okay. There's been a lot of studies done in medicine about what they call cognitive biases. So when I started to read this work, I thought, hang on a minute, this is not just medicine. Nurses do this too. We're making errors all the time because our reasoning is influenced by our biases, our prejudices, our overconfidence sometimes. And it's a bit like if you think, despite the fact that we're trying really hard at Newcastle not to have students with ageist attitudes, some of them do have ageist attitudes. So they'll see a confused older person climbing over the bed rails and they go, dementia. As soon as they give them that diagnosis, the thinking stops because dementia, it's inevitable. What can you do? And I say, step back. What if it's not dementia? What if it's delirium? And if you don't do something, this is a serious situation. But it's a bit, if you have any attitudes, an assumption, young people don't die. Young people are pretty healthy. And I'm going to show you a movie later, a film later, that assumption is so dangerous. As soon as we assume something about a person, then our clinical reasoning is halted or influenced in a negative way. So it can be before we even start clinical reasoning, or it can be woven through the clinical reasoning process, that our errors, our assumptions, our biases, our judgments negatively influence what we do. So I'm going to show you one in particular. Fundamental attribution error. The tendency to be judgmental and blame patients for their illnesses rather than examine the circumstances or the situation that may have been responsible. And psychiatric patients, those from minority groups and other marginalised groups, tend to be at risk of this error. So let me show you this film. A little bit about this situation. This was filmed at Edith Cowan University. Edith Cowan have you been there, Angela?
No, I missed out on a trip last week.
A $56 million simulation unit. Can you imagine that? I'm very envious. But they do a lot of work with Department of Health. And so there was a situation in the Department of Health where something really serious happened. And so Edith Cowan University were commissioned to bring all the health professionals together from that particular area and other areas, so there's about 300 of them, and they brought them into a lecture theatre, and live streamed into that lecture theatre was a reenactment of the case that had occurred. And they had two stages. So they reenacted the case following exactly what happened from the coroner's inquest report. Then they went in to all the actors and everybody went in and sat with, now I have to tell you the health professionals didn't know it was a real case, or actually some of them did, but most of them didn't. But then the actors and everybody went in, and when they went in to the big auditorium, the health professionals were just chatting and they were a little laughing and da-da-da. And they said, this was a serious case, what's happening? And they didn't believe it was a real case. It actually was a real case. Then they got them to all go back. They told them what went wrong, and all the health professionals said to the actors, go back and redo it this way. So this is a synopsis. It's actually an hour-long video. I'm just giving you a 1-minute synopsis of the case so that you can see what you think.
Can you all hear me?
Come back a minute, 2-year-old.
So you're laughing.
Jesus Christ, Olive, don't worry. That was bound to happen anyway. I knew it was going to happen. This is hopeless. I can't do a thing with this guy. No, I want you to take him to the police station. He's fine. He's obviously just pissed. I've had enough of this. Disturbing the police peace down here. I'm trying to look up the place of I've had enough.
Sorry, just take his details.
Oh, Dr. Goldman? Yes, it's Judy Rogers down in ED. Yeah, Matthew Jenkins, he's right to go. Oh, he's been thrashing around, just being really aggressive, very, very drunk. Yeah, but his ops are fine, he's stable, he's moving all his limbs. Yeah, his Glasgow coma score's about 15. Yeah, it's been stable the whole time he's been here.
Okay. So you're laughing too. You're thinking that couldn't possibly happen?
No, I was just laughing when they said the Glasgow.
They are actors, but honestly, they had a script that they were working from. I mean, the script was based on the coroner's inquest, so that was the report. So what do you think when you see that? What's going on?
Well, someone's made a judgment that the guy's just pissed and that he's just trouble. So get him out.
And it's a pre-bias because she's seen it
pre-bias.
100 times before, and she's just made a clinical judgment based on that fact.
Absolutely. Yep.
He doesn't only look drunk to me.
He doesn't?
No, I wouldn't be, anybody throwing himself around like that, I wouldn't be saying his name is drunk.
Yep.
He's most likely in pain and there's an underlying thing. Does he have some sort of brain trauma that has occurred before he's presented?
Yep. Anything else?
I think it's disturbing about the lack of care.
Yep. Well, let's look at the nurse. What did you think about the nurse?
She wasn't very caring. She's quite aggressive in her, like she was obviously stressed. She's probably got 5 other people that she's responsible for, and here's someone who she can't do anything with, and she's conscious that she's got all this other work to do. I get that, but she didn't display any, she didn't even attempt to try and work out what was going on here. She didn't
display any compassion.
No.
No compassion. No person-centred care. But I'm talking to you about clinical reasoning, and I talk about person-centred care almost as if it operates in a vacuum, almost as if it happens in the perfect world. It doesn't. It's, patients are put in the middle of complexity. There's a whole lot of other situational factors that are going on. And it's so easy, I think, to look at the nurse and say, oh, bad nurse, bad nurse. But what if I told you that this nurse, this was her 12th night duty shift in a row. They were very short-staffed, and she'd had 2 days off, but they'd been cancelled. So she was exhausted. They were short-staffed. She had very few people to call on. The doctor that was working that shift wasn't experienced, and he was not actually in the emergency department at the time. So she was basically it. Now the other thing is she knew this young man. It was a small community. She knew the young man. She knew his family. It was a community in northwestern Australia, high Aboriginal content, high degree of racism in the community, in the healthcare workers themselves. He'd been in trouble with the police numerous times. He'd been presented in hospital, drunk and disorderly numerous times. And when she heard his name, she thought, here he comes again. So she had preconceived idea about him straight away. She also knew that, and this is because nurses don't operate in a vacuum either. We are people first, nurses second. He had just gotten his 16-year-old girlfriend pregnant, but this nurse's daughter was 16 and had also just gotten pregnant. Not by him. So she had all this going on, and he's done that. So she was a person first, exhausted, stressed, pretty much on her own. And pretty much had seen this happen over and over again. Now what ended up happening was she just said, get him out of here. The police dragged him by his legs out, threw him in the paddy wagon, took him to a jail cell. He died in the jail cell. He hemorrhaged to death. He actually had fractured pelvis, fractured femur, and internal hemorrhage. Okay, but none of that was assessed because the nurses, the situational factors, the nurses' own personal experience, but there was no clinical reasoning occurring at all. You also saw how she couldn't actually take his blood pressure, so she didn't actually have any cues to work with. But also that eternal optimism came in and thought, just get him out, he'll be fine. He'll be fine. Without predicting, what if he's not fine? What if he's not drunk? What if there's more to it than I'm seeing? And you may think, well, that's a pretty extreme case, but I'm not sure that it is that extreme. I'm going to show you another film here. And this is one, our students, I told you, learn about clinical reasoning semester 1. Our first year students also learn about patient safety. And this is the case they use. We developed this with the New South Wales Clinical Excellence Commission. It's actually a 60-minute long video that they watch. This is just a snapshot of it. It's only about 7 minutes long. And it tells the story of Lewis Blackman, a young boy from America. But what I think it gives you is takes it beyond patient safety, takes it beyond clinical reason, takes you into the person and their family. So I'm going to show you that now. So like I said, it goes for about 7 minutes.
We had seen a newspaper article about a procedure for a condition called pectus excavatum, which Lewis had. It's a congenital condition that is fairly common. 1 in 200 to 1 in 400 children have it. And the sternum doesn't grow straight, so the chest has sort of a concave appearance. So it was a cosmetic condition for him. And we had seen this article saying that there was a new minimally invasive, very safe procedure to correct it. When he went into the hospital, he was slightly dehydrated. He was not producing urine. And after his surgery, he was prescribed a very low IV drip, something more appropriate for a small child than a 15-year-old boy, certainly not for a 15-year-old boy who was already low on fluids. And we could not get those orders changed. Finally, a pharmacist found it, and there happened to be a very receptive nurse who was a knowledgeable nurse. Most of them were very young, and they were not going to challenge anyone. But this was an older nurse who really knew what she was doing, and she and the pharmacist got the orders changed. For his pain, he had an epidural with hydromorphone and bupivacaine, and he had, for an adjunct medication, IV Toradol every 6 hours. The narcotics were up to, very high levels, sort of dangerous levels for somebody who was opiate naive. And then the ketorolac, which they kept giving, and it seemed to really have no effect on the pain. So he went in for surgery on Thursday. It was Friday afternoon before we got the fluids regulated. Saturday he was still, he was sweating, he was itching, he was nauseated. He didn't eat the whole time he was in the hospital. At 6:30 Sunday morning, which was half an hour after a Toradol injection, he was suddenly just stricken with this excruciating pain in his upper abdomen, quite a different place from his chest pain. The nurse came running in. She was just leaving the shift change, and she was quite alarmed. And she sort of ran out of the room, and then a few minutes later she came bustling back in and said, "Oh, it's nothing, it's just constipation from the narcotics." That was the diagnosis that stuck through thick and thin, through every sort of evidence to the contrary. That was the diagnosis he had. Over the course of 30 hours, he continued to deteriorate. He became septic. He exhibited signs of shock and dehydration. He was fairly obviously in bad shape, and no one did anything. Monday morning came, and when they came around to take Lewis's vital signs, he had no blood pressure. And there was just the assumption that couldn't be right, because how could a healthy child in for elective blood surgery have no blood pressure? They took his blood pressure 12 times with 7 different cuffs and machines. So they tried to take blood, and they couldn't. There wasn't much blood there. They were trying to squeeze and wring his arm to get some blood out. While they were doing this, he looked over at me and he started saying something I couldn't understand because his words were slurred. And he said, "It's going black." And I said, "What?" And he repeated it, with great difficulty. I just stared at him. I didn't know what to do about somebody saying something like that. And then suddenly he just arced into cardiac arrest. And his body went at all angles and his eyes were staring. And he was dead. One of the things that people don't talk about because it's so personal is what happens afterwards. The effect on families. My daughter's childhood ended that day. She was 10 years old. She lost her parents at the same time as she lost her brother. We had one of those houses where all the kids came, all the teenagers came. Suddenly, our house was silent. And that's just part of it. It goes on and on. It echoes through the generations. Every time my daughter reached a milestone, it was a sad milestone. When she turned 18, we all cried because we knew who had not turned 18. I think that one of the big problems with what happened to Lewis was that people were following guidelines and protocols and were not looking at the patient. All the way through, there was a plan, and the plan did not include a complication. Patients need their caregivers to look at them as individuals, is the first thing. They need their caregivers to take their symptoms seriously, and they need their caregivers to research the medications that they're on. It's not just not to make assumptions. If someone is exhibiting a symptom, you need to find out the correlation of that symptom with their medications. To me, the overriding problem is just the lack of respect for the power of medications. People really don't, providers don't realize, and patients don't either, just how much harm a medication can do.
So Lewis's mother focused on medications and medication safety, but I see that the medication safety was caught up in the clinical reasoning. Where were the opportunities for clinical reasoning to kick in Lewis's situation where they didn't engage in any?
Right from the start.
Right from the start?
When he was dehydrated.
Yeah.
Dehydrated, yeah, absolutely. And say, is it normal for this boy at this time in this place? And if it's not, what are we going to do? And then?
The whole thing.
All the way through. I think the one thing that stood out to me was the assumption that this young boy must have blood pressure. Obviously, it's the technology. You could see them going, I could just imagine, using automatic blood pressure machines, which I think are inherently unreliable. That didn't work, and then getting manual. And obviously it's the sphygmo fault, because he's a young boy. He's got to have a blood pressure. Without saying, and also that it was so many nurses that must have been involved in that 5-day period. And so many nurses that, when the blood pressure wasn't right, there must have been others saying, why wasn't anyone saying, let's look at him? Let's look at his tummy that was distended. Let's look at his, respiratory rate that's through the roof. His pulse rate was through the roof.
It's almost as if because there were so many nurses involved that everybody's going, well, everybody else has seen this. Nobody else has reacted. Why would I react when the person standing beside me who is an expert hasn't reacted either? It's sort of that fear of being the fool, of pointing out the obvious when everybody else is looking at the...
So comes up with that patient, he's normally not alone that patient.
Yeah. I think they're really perceptive points. I used to, when I was an educator, I was on the nursing and medical peer review committee, and we would look at anyone that was an unplanned admission to ICU, anyone that was an unplanned readmission within 24 hours of discharge, anyone that was referred to us, and then a 5% random audit of all charts. And it was amazing. When we looked at things that had gone wrong, we could track back and see that it had happened over shift. And it's almost like if you pass it on through handover, complaining a lot of pain, but I think he's okay, then everyone would say, yeah, complains a lot of pain. not, is he okay? You know, it's like we're preconditioned. And it,
Might
particularly,
have had that pain this morning. It's not new.
yeah. So, you know, no one really overreacted this morning, so am I going to put my hand up and say this is not normal? And also the fact that she said finally after 2 days and a knowledgeable and experienced nurse came on. You know, dehydration is not rocket science. You know, knowing what to do about dehydration is not rocket science. You don't need 20 years of experience. But did you also see how she said they wouldn't challenge? I think that's one of our biggest problems. We don't challenge, we don't say this is not good enough. I need you to, and that's why we've got those escalation systems, and I'm sure you use those between flag charts, or probably got a different name here, that says in this situation you must phone. And I'm hoping that has some impact. But I'm going to share with you some of the research we've done about communication with new graduates after lunch. We've got a lot of work to do in terms of challenging. And not just nurses challenging doctors, although that's what we tend to think. It's a bigger problem than that. So I think the saddest thing is that this is, and the reason I use this one for students, and we've got other ones, we've created reenactments of a number of coroner's inquests. And the reason I like them is because it's the person that's up front and centre. So I say to students, patient safety. It's not something you hear just on the media. It's not just a statistic. It's not just a medical problem. This is about people. And one of the ones we've created is a reenactment of someone called Vanessa Anderson, who was all over the media for 5 years in New South Wales. She was hit in the head with a golf ball. She went to a hospital and she died from a respiratory arrest as a result of opioid overdose. Completely preventable, but you could see all along anyone could have stepped in. And I say to students, the first year student could have said, is the amount of medication that 15-year-old girl having normal for that person at that time in the case? It's actually double and triple in some cases. So she had so much, but no one said, this is not normal, this is not right, and no one stepped up. But we do the same thing. We show Vanessa as a child because I want students to say, this is not just something that influences nurses and doctors and healthcare. The ramifications of these tragic situations go on for year after year after year. And I have seen the destruction caused in Vanessa's family as a result of the grief, the anger, the despair. So this is something we can do something about. So, this is what I firmly believe, and there is some research to say that anything you teach at an undergraduate level, whether it's communication, person-centred care, things like clinical reasoning, if you teach it in a way that's effective, it will become firmly entrenched in graduates' ways of operating. It's no good. We have an integrated curriculum, which means we revisit all the important things every single semester. Person-centred care, research, ethics, law, clinical reasoning, they are threaded through our whole degree. We don't have a law subject, we don't have an ethics subject, they're just threaded through. And the belief is that it will become so firmly entrenched that it will be unshakable. So even when graduates are working in complex, difficult, sometimes unsupportive healthcare environments, they will know what's right. Even if they don't always do what's right, they will know. So I firmly believe we can't wait to teach recognition and management of the deteriorating patient for new graduates. Okay, I just think we can't, ethically we can't wait. But should we be teaching it on campus, or should we be teaching it off campus, or should we be doing both? Should we just let them learn from their mistakes in the safety, I hope, of a simulated environment or the unsafe clinical environment? Or should they learn with clinical support, or do we hope, and I see students that learn about clinical reasoning because of the support they get in practice, and some learn about clinical reasoning lack of support they get in clinical practice. So you tell me, where, in your experience, where is clinical reasoning best learnt?
Everywhere.
Who said that? Yeah, everywhere? Whenever we have the opportunity? Okay. So then tell me, how do you do it?
Well, you start with undergraduates, so you start with them going into practice. And everybody will have that clinical reading.
Yep. But what were you going to say?
I was going to say, on my practice as a student, the best teachers were the ones that asked me what do you think's going on here, or what, instead of just, telling me.
Yes.
Asking me to.
Prompting you to
prompting
think.
me to think.
Yeah.
And say what I thought.
Where's my bag? I'll grab my bag because I've got a story to read you. It's exactly what you've just said. One of my second year students, thanks Angela. This student was quite a shy student, and she was a little bit dubious about this whole idea of clinical reasoning. She thought it was, she was just starting to work as an AIN. She just thought, can we just get on? I remember her in first year, she just wanted to get on with being a nurse. We were teaching all this, communication, all this stuff. She just wanted to do nursing. So I remember her, and then she came and I wasn't teaching first year, I was teaching second year, but I met her in first year, sorry. Then she came into second year, and she happened to be in my tutorial class, and we do a lot about, all our scenarios are structured using the clinical reasoning cycle. And she'd roll her eyes sometimes and go, I don't think this is what's going to happen in clinical practice. She was a little bit knowledgeable. So she sent me this email. This was her very first shift working as an AIN. She'd started her BN degree 12 months before, and first shift she was asked to special a confused and agitated 78-year-old man during a night duty shift last Friday. So I'm just going to read the email to you. She said, the only goal the RM wanted me to achieve was to get him to have a good night's sleep. So I went in and did a set of obs. He was hypertensive, tachycardic, he had tachypnea, his temp was slightly elevated but still afebrile. At around 11 he wanted to go to the toilet, and he was quite vocal in doing so. I love her language. He retreated to his bed, and then I asked him if he was experiencing any pain while passing urine, and he said he was. I asked him to rate the pain, to which he responded 9. I observed his medication chart and noticed that he was due for some PRN Panadol 2 hours beforehand. So I approached the RN on duty and updated her with the information I'd gathered about the patient. Then she administered his Panadol and pulled me aside and asked, okay, you've brought this patient's situation to my attention. What should you be doing at this point? I froze. I responded eventually with, there isn't a fluid balance chart in place, so I'm unable to determine if his fluid input or output are okay and whether he's in a positive or negative status. So she prompted me again. So what are you going to do about it? I said, I'll put one in place. So what would you do next then? She said, well, perhaps I'll attempt to get a urine sample and test it to see if there's any bacteria or protein present. So the next time the man went to the toilet, and I did a dipstick to test his urine output, but it all came back perfect. So I was stumped. I honestly thought he had a UTI. I honestly thought I'd solved the problem. So I gathered my thoughts about me, and the RN kept prompting me, and I thought, what will I do for this confused old man? So when I did his obs again at 4, I had the same readings. He went to the toilet, and I could again hear him straining. I left him to it and then approached the RN and said, I think we should do a bladder scan. And I gave my rationale. So the RN did a bladder scan and was amazed that he had 965 mils in his bladder. My mind was trying to remember how much a bladder can normally hold and if this was normal, but I was certain it was around 300 or 350 mils, and the RN confirmed that. So at 05:15 the man was catheterised. The poor man had urinary retention, and I was amazed that the cues weren't picked up prior to me getting there. The RN gave me a big thank you and said, you did a wonderful job. I was walking on cloud 9 and so proud of myself. So the moral is, I thought I knew nothing until up until this incident. I didn't think I was retaining a lot of what you'd taught me at uni. But it was like a light bulb moment that just went off, and I found myself thinking about the clinical reasoning cycle often during that shift. And I can honestly say that now I see the significance of it. And the biggest thing to come out of it was I was beginning to think like a nurse. And I am so grateful to that RN that didn't just solve the problem for her. you know, just kept prompting. And I suspect she was probably busy and had 1,000 other patients and things to do, and just said, well, go and check, go and check, go and check. But, you know, that's a great thing to do for students, because what we want them to learn is to think and to process. And even though that was a clumsy approach, she was clinically reasoning, collecting cues, saying, is that normal? What could I do? You know, and her action was to go back to the RN and make a suggestion. Perhaps we'll try bladder scan. So I just think, you know, by the prompting, by not jumping in, by not giving all the answers, we can teach students to think. You know, and it's much more challenging to teach them to think than to do skills. And it's sometimes challenging to step back and not solve the problem for them, particularly when we know what the answer is. So sometimes there's safe environments where you can do that. Sometimes it's not safe to step back. I'll give you another story. It's also about, interestingly, I worked on a urology ward, so it grabs me because it's about urine. This girl went into a child and adolescent, this is another one of my students, went into a child and adolescent mental health unit. And she had this little 14-year-old girl that had a lot of different mental health issues. But they said to her, I want you to distract her this afternoon. That's your main goal. She'll complain of pain. She always complains of pain. Today I think it's abdo pain. Tomorrow it'll be some other pain. Distract her. Take her outside. Play basketball with her. Play chess with her. Just keep her distracted. That's all you've got to do. So my student, who was one of those students that was bright but quiet, and you know, she would go red from here up every time she answered a question in class. So it was not outspoken by any stretch of the imagination. But she spent time with this student and she took her outside. Come on, we'll play basketball. Come on, we'll do this. You know, let's watch a bit of TV. What do you do at school? Blah, blah, blah. And she said, I couldn't distract her. She just kept grimacing and holding her tummy. And in the end she thought, and she was first semester, second year as well. And in the end she thought, maybe I should do some clinical reasoning. So she said, I palpated her tummy, but had no idea what I was feeling because I couldn't do that. But she said, I knew that was the right thing to do. She said, but didn't know what to do. Did her obs, they were okay. I thought, you know, what else? Went through a medication chart and thought they all look okay to me, but then started to look up the side effects of the different medications. And one of the side effects of one of the medications was urinary retention. Anyway, she went outside the mental health unit with permission, got a bladder scan. She had 1,500 mils in her bladder, a 45-kilogram little girl. So she didn't tell me, but when she came back to my tutorial, I said to her, what have you been up to on clinical? I've heard about you. She went, what have I done? What have I done? But it was actually the CNC on the ward and rang and she said, I need to tell you about one of your students. You know, and it's because she continued. And so the affirmation for her of knowing that clinical reasoning actually works and speaking out when it's really hard for students to speak out. So this afternoon what we're going to be doing is thinking about how can we really teach clinical reasoning, how can we assess it. But I want you to come up with ways that you're currently doing it and probably even aren't even aware that you're doing it, ways that we could do it. You know, where are our opportunities? And we're going to be talking more about that. I think that's the very last, it is the last slide. So, it's time for morning tea, I think. Thanks, Jay.